Good evening, everyone, and welcome to our week 8 of our PRI Breathing Mechanics in COVID Times webinar. We're excited to once again see some familiar faces on with us tonight. Tonight's title is Somatosensory Processing of Respiratory-Based Right Thoracic Rotation and Expansion.
Good evening. Thank you for joining us. Thanks for being here. This topic of sensory processing is an important topic when we relate it to what we really have to have before we can breathe comfortably, and that is a sense of ownership, a sense of what's doing it. What are we actually doing when we take a breath? And all of you know that the importance of understanding that you've got a sensory system that's really built off of two parts of your body, a left one and a right one. Sometimes have a difficult time communicating with each other because of transmissions that gets broke down. So tonight we're going to talk about, I put SPD up here on the board, sensory processing disorder. And I don't want us to think, Jen, about POTS patients or patients who can't find the floor this evening. What we're going to talk about are patients who can't find chest walls this evening, can't find their thoracic chest wall. And before we get too far into the topic and the meat of the program, I'm going to be focusing a lot on thorax intercostal nerves, sensory input coming into your brainstem from T7, 8, 7, 7, 8 up. Everything below 8 is really abdominal intercostals, thoraco-abdominal intercostal nerves. Now they're also very sensitive, but they're not as meaningful to us in this talk we're having this evening because they are a little bit further removed from the top of the dome of the diaphragm where everything starts to happen. And so when we look at the top of the dome of the diaphragm and in that general region, we need to be aware of what's really going on in those areas, what's going on underneath your rib cage at the collarbone level. And slightly above it, obviously, there isn't much up there other than rib 1. And then between that collarbone all the way down to T7 and T8, we want to maximize our awareness of where are we? How are we breathing? Because breathing doesn't occur on its own. I mean, breathing occurs by someone who owns the chest wall and has to carry it all out on their own, which all of you know. So the title says, based on thoracic rotation and expansion. And we'll talk about rotation and we're going to talk about expansion here in a few minutes. All of us has a need to process and organize this information for reproducible activity. We have a brainstem that feeds itself information. Our brainstem feeds itself information. You just took a breath of air in, therefore you're going to have to blow it out. If you blew it out, you're going to have to take a breath of air in to replenish what you just blew out. It's a self-driving system, so to speak. When we lose our phrenic capabilities, we don't do very well. And one of the neat things about our body is that activity, that reproducible activity, is often not experienced in a sensory way because it's given to us, so to speak. We don't have to work hard at it. If you had to work harder at something, you would start relying on your senses more. When you pick up a cup like I just did, you'd have to rely on your tactile sense for tactile feedback. You'd have to make sure that it's in your hand, otherwise you don't know you got something in your hand to drink. And you wouldn't know how to get there if your body did not have sensory input coming back to it at the time you picked it up. Now, when we breathe, we don't really think that way. It's just automatic. We have 3 primary ways of making that automatic. We sense processes. We sense processes through sensory modulation, sensory-based motor function, and sensory discrimination. That's how we make sense of what we do. And I always felt earlier on in my career and life that it was really important to feel things at the bottom of my feet and with the palms of my hand, because I always assumed God gave us these two areas, the palms of your hand and the plantar surfaces of your feet, for sensory representation of what we do in life. And I probably couldn't have been more incorrect. Most of the sense that we get with our body comes not from your hands and not from your feet. It comes from arms that move next to ribs when we walk. That's why our arms hang down. The biggest sensory component we have in our body that we don't think about, Lori, is what's going on between the arms and your thorax, specifically from the elbow up. And from the elbow up is your diaphragm zone up. So every time I put my hands by my side and I feel my shirt or my skin rub itself on my skin, I know I'm here. I know I'm present. But if I took my arms by my side and raised them up and I kept them away from my body, I would start wondering, where are they? And once I start wondering where my arms are, then I start wondering, where am I? And then I get a little anxious. I get a little bit, whoa, I got to do something. I got to bring those arms by my side or feel something. And that's the role that our brainstem has in saying, you know what, don't worry. I've got some intercostal nerves. I'll tighten you up a little bit autonomically. So your somatosensory system, your somatic nervous system, can relax a little bit. Somatic sensory system. That's what we're going to talk about this evening. And our somatic sensory system is driven by our thoracic intercostal nerves. And that's why it's so important for us to talk about that in this webinar series for next week when we have fun about arm swing and arm motion. Now, we've been building a platform in this little movie theater for the last 7-8 weeks, and we're just building it slowly to remind you that breathing is a lot more than just, as I told Jen this morning, lung tissue. We're trying to lay all those areas of sensory, soft tissue, muscle, everything that's organized with how we move around what we do without thinking about it. And that is, how do we move around our breath? So what do we do to really make ourselves breathe a little bit more easily? Depends on how we process that information, which is what we're going to talk about this evening. Each of these primary patterns of organizing disorders has underlying or organizing patterns, whether they're dysfunctional or not. Tonight, we're going to be talking about patterns of disorganization, disorders, patterns that are poorly organized by how we sense. And each one of these primary patterns of organizing disorders has underlying sensory processing impairments and one or more of the 7 sensory systems. What are those? Auditory, visual, gustatory, olfactory, somatosensory, big one, which includes touch and proprioception, which is what we're going to talk about tonight. And then we're going to talk a little bit about the vestibular system, and you can't talk about any of them without considering the interoceptive experience. Where am I? Who am I? Was that my gut that I just felt? Was it something that is coming from me? Interoceptive. So you see this figure from Stein. I've used this book for years, and I love it. It's got many, many chapters by many, many authors. And I absolutely just love reading it. And I think I've about read every chapter, but this particular one has always caught my attention because they have done a very good job at describing these 3 processes of disorders. And yet it's built off of normal processes of order, normal processes of order. Every single one of us either are over-responsive, under-responsive, or crave for response, crave for sense. And that would be the modulation. That would be how you alternate and you oscillate. That would be how you breathe. It's modulated. We get enough or we don't get enough. We're somewhere in between. Some days there's more, some days there's less. You put certain sweaters on and you have too much. The wool seems to bother your skin. You put a piece of cotton on or you put a t-shirt under it, you're now much better in responding to that sensory input. I hope by the evening, by the end of this discussion this evening, you will all appreciate that your sensory organization from your palms and the plantar surfaces of your feet are all tied into your thorax, because the thorax sets the stage for heightened or non-heightened awareness of sense. Some of us like to go to bed at night and sleep with nothing on their thoraxes. I happen to be one of those people. I like to have really the freedom to sense what I'm doing in bed so that I can make sense to myself. The more I put my clothes on my body, the more I'm lost. So that doesn't mean that's true for you, but every single one of you has a modulation of sensory input coming from your thorax that belongs to your reticular system, belongs to your basal ganglia, not your neighbors, not your spouse, not your significant other, not your kids. It belongs to you. And that pattern of sense is coming from this modulated activity that you gained throughout the day when you were awake, and you made reference to it over and over again. I could change the way you hit a ball, and I can change the way you're going to throw a ball by what I put on your thorax. These are things that are incredibly important. I'll tell you what you put on your thorax is you put a demand on your thorax when you can and cannot breathe. The number one garment you carry around is an piece of underwear. It's called your pleura. And then on top of that, you've got maybe a t-shirt called rib cage or intercostals. And on top of that, you may have something else that's layered. And that layered makes it apposition-minded. Things are moving on each other. That's sense. That's thoracic intercostal sense, which is what we're talking about this evening. Obviously, you can see I can talk a lot about this because that responsivity precedes all your motor activity that you're trying to acquire with the sense of control. Then we have your sensory-based motor activity, and that's things like postural disorders and dyspraxia and issues that sometimes happen when you have a stroke, or sometimes happen because you maybe cut your foot or whatever it might be, or an arm. But postural disorders fit in this second category. There's one common theme to the first category. The one common theme, usually when you have a sensory processing disorder in the first category, you are under-responsive. You don't see disorders with over-responsive activity, usually. You see this modulation problem being an under-responsive activity. You're not responding because you don't sense it. You don't know it's there. This evening, I'm going to show you 3 techniques that I think there might be 3 or 4 techniques in your handout that's going to address some of the ways you can actually take your palm of your hand and make sure you understand the palm of your hand belongs to somebody. It belongs to you. It belongs to that palm. Instead of looking at what the hand's doing, what's your thorax doing for your hand? Think of that this way this evening. And then when you look at the when you look at this sensory-based motor disorder, postural disorder, the number one problem with that is people who lose their rotation of their trunk fit in that category. I'm going to give you 2 techniques tonight that are going to fit in that category. There are many more, but I'm going to give you 2 so you can discriminate between those 2 when you might use them and for what reason. And then finally, this sensory discrimination disorder. Individuals who do not know how to take multiple senses and put them together. That would be your POTS patient. That would be your patient who's sitting there going, I'm dizzy. I don't have enough carbon in my body. And when I get it, maybe I don't know how to use it because everything is now making sense. But if I look at one thing and I'm so visual minded, I may drop off the other 6 senses. I may not hear something. I may not taste it. I may not feel it. My interoception of me may go down the minute I stare at something. The ability for them to put all those senses together is a problem. And that's why it's called multiple sense vision integration. and I think you have this handout. I think Jen mailed it out. I like to look at our senses the way this author describes them, and it works very well when you start looking at neuroscience of both the autonomic nervous system and the somatonervous system. Now this evening I'm going to cover, there isn't a lot of slides, Jen, but I'm going to cover a little anatomy, and some of them may be boring, but I think it needs to be discussed if you're really going to appreciate why you do things the way I would do them, or why you would want to do things the way I suggest you do them, with the techniques that I'm giving you. But out of the three primary patterns, the sensory modulation disorder, this one, has the greatest influence on all of our abilities to sense ourselves and sense the activity regulated by not only us, the producer of the movement, but the degree of it. That's the big one. So the more you use your arms when you walk, the more you touch your body, the more you're aware of yourself with your appendages, the better off you're going to be in modulating yourself. We were built that way. That's how we're designed. We were built that way. That's how we designed to move. Our bodies can't move very well without it. Just keep that in mind. Our bodies get lost in our bodies. Think about it. You're sandwiched between these appendages up here. And the important thing is to make sure that the appendages are working so you can feel the two pieces of bread on the outside of that, whatever's in between that sandwich. So this is what you're really should be all about when it comes to respiration. Respiration requires a sense that there's actually a body producing that air, producing that gas. If you don't have that sense, your ventilation could be just fine. Your perfusion could be even fine, but you're going to be lost under duress when other things come in your life, like all of a sudden you're in a situation you can't rotate, or all of a sudden you've got so much coming at you, bright lights are spinning around you, and you don't know what to do with yourself. The first thing you're going to do with sensory processing disorders, please write this down, you're going to hold your breath. You're going to hold your breath, and then you're going to start the process up where it's fast and it's furious. It's going to be quick and it's going to be fast. Those breaths are going to be shallow. They're not going to be deep. And the next thing you know, you start to collect things. O2 molecules, you like to collect those. You become hyperventilatory. And as you become hyperventilatory, not only is your modulation a problem, but you're feeding that anti-modulation position you're in. And now your ability to perfuse goes way down. So this is an important slide. This is not just a casual discussion about sense this evening. It's a casual discussion if you just want to talk about sense as it relates to your body. But when we talk about relationship to how we breathe, these three subtypes are all important to look at with respect to how you breathe. There are three subtypes of this pattern. As I said, sensory over-responsiveness, sensory under-responsiveness, which I told you is the primary issue for those who overuse their right lateral respiratory muscle during postural perturbation challenge. People who love to stand on the right side are definitely going to be in this under-responsive position. And they may they may want to get out of it, but the more they crave it, the more they get into it. They're feeding themselves the need to become very locked in and under-responsive to their own body movement because their body isn't moving. So they're underserved, if you will. Individuals with sensory under-responsiveness are usually slow to respond to sensory events like right lateral chest wall expansion when standing or sitting with more weight distributed over their left hip and foot. They have less intense responses than are typical. Their sense of expansion at the right lateral and superior chest walls and left posterior chest walls is diminished. It may even be more than the other side, but because they don't sense it, they don't feel it, they don't think it is, and require more intense stimuli to respond to the demands of the situation, because inhalation using left internal obliques and left transverse abdominis and left external intercostals, which are inhalers, which you learned last week, and right external obliques and right internal intercostals, which are exhalers, have to be worked hard for them to sense it. The more they sense themselves, the less hard it is, and the more they're going to carry it out without having to go find more sense. Very important slide. The second primary pattern, the sensory-based motor disorders, relate to right thoracic rotation limitations and refers to the associated difficulty stabilizing the left body and sequencing coordinated movements with the left body. Ignorant, left-minded people fit into this category. If the more they lose the awareness of their left side, the more they become a SPD type of patient with a sensory-based motor issue. These people are motor, I'm going to be very nice, I'm not trying to hurt anybody. They're really moronic. They're motor morons. They do not know how to move because they don't have the ability to sense the movement even when they do it because they're unilaterally minded with sense. I hope that made sense. And I wasn't trying to hurt anybody, but these are the individuals that really need not only to get over to the left side and find that PRI left activity, but to actually sense it and to actually sit there a minute and touch it and feel it and know it. And I think, Jen, we gave 2 activities for that activity this evening for you to reflect on. You can do this with a lot of different techniques and a lot of other programs besides PRI. It doesn't mean that this is a PRI moment we're having. It's not. But one of the reasons why I think those techniques work so well is because we're not unilateral-minded people if you do any type of work with PRI. We're bilateral-minded people. We're bilateral, asymmetrical symmetry-minded people. Symmetry is based off of bilateral asymmetry. And this is why this slide is so important when you look at rotational issues. Individuals with the poor sense of body planning are assumed to be the result of inadequate processing and discrimination in one or more of the following areas, following sensory domains. So the body planning, visual, tactile, proprioceptive, and vestibular.
On the left side.
On the left side. Did I say that? Okay. Is it on there? Okay. Missed it. That's why you're standing over there making sure I'm honest. But that's a big part of the slide, actually, Jen. On the left side, Jen said. On the left side. Are you mic'd up? Yep. The third primary pattern, which is this sensory discrimination pattern, is characterized by problems interpreting and deriving meaning from that sense. What did that sense do for you? What did it buy you? What did it give you? What was it worth, by the way? Joy, what's that? You know, what's so good about that sense? Why would I even want to get it back? Tell me, how much would you pay for it? What does it mean to you? Is it more important than the shoes you put on? And if you can get to that level, if it's more important to the shoes you can get on, I doubt you'll have any problem with any of those SPD issues ever coming. Because we don't put importance on our thorax's sense. We put importance on the bottom of our feet. Now, I'm only trying to make sure all of you understand how silly I sound. But you sound more silly to me when you're worried about what you feel in the bottom of your feet, when I know the bottom of the feet are totally responsive and responsible for what you're feeling when you breathe through your thoracic intercostals. That's not silliness. That's factual. You're going to find that here in a few minutes. So what's it worth to you? What is it worth to you to actually derive sense, a meaningful sense of sense coming from the upper and middle part of your thoracic cavity, front, back, and both sides? Tactile is knowing what it is, what is in one's hands or under one's hands without looking. We're going to put something underneath those hands tonight. It's going to be you. You're going to put yourself underneath your own hands. Because if you're not doing that once in a while, you're not really experiencing true sense. That's false sense. This is false sense. When I touch this, Joy, false sense. This is true sense. This is sense. This is my sense. That's true sense. If I touch Jen, that's false sense. In fact, that sense is even more confusing because it feels like there's something under it breathing. Because the sense of what she has is cycles. The sense of what I have is cycles. There is no cycle in this material. Sense is cyclical. Sense is respiration. When you look at individuals with this sensory disorder, you require slow processing. It's not fast. Stop and smell the scents, not the roses, of specific non-multiple sensory stimuli, preferably with your hands. Use your hands for meaning. Use your hands to make sense. Tactile sense. It's one of our main senses. How about if I told you it's your number one sense? I've got a little granddaughter who's now feeling my hands, because when I put my hands, and she's got these little hands, and I can sense when she senses me with my hands. And she's using her hands constantly going to her face. She's just starting to figure out who she is. She's just starting to talk. Babies don't talk and coo, which she just started doing, until they touch themselves and they know that they have a body to coo with. Why do we think we're different? So I'm just inviting you to start resonating a little bit with how you sense to yourself. This is called somatosthesia, somatosensory system. It's as big as the autonomic nervous system, and the cranial course I talk about all three. But we're talking about it today because we're relating it to the most important sense that you have, intercostal sense. Last week we talked about these intercostal muscles that need to have this agonistic and antagonist sense. And the only way you know that you can control yourself is that you make sense. You feel it. You're not flying apart, because you're crossing multiple areas of those intercostals when your hand goes on it. The ribs are smaller than your hands. You're touching 4 or 5, maybe 6 ribs if you really get good. But for the most part, you're not just on one. The perception of tactual or proprioceptive or gut sensation is called somatosthesia. And the intercostal nerves are really good at it. They supply innervation to the skin, the muscles of the chest, and down to the abdominal walls. Unlike the nerves from the autonomic nervous system that innervates the visceral pleura of the thoracic cavity, these intercostal nerves arise from the somatic nervous system. This enables them to control the contraction of muscles, as well as provide specific information regarding the skin and parietal pleura sense. So here's a picture of those it's just a straight down transverse view. You got the lateral cutaneous nerves on the outside. On the inner side, you got this intercostal nerve. You can see that intercostal nerve, and I don't have a pointer, but just go on the inside, right there between the pleura and the intercostal muscle. You got this intercostal nerve, and the rami communication goes on. The sympathetic ganglion's right there. Transverse thoracic muscles right there. I just wanted you all to see the word lateral cutaneous and anterior cutaneous and posterior divisions of the cutaneous. Wraps around. That nerve makes what we talked about last week real. Without those cutaneous nerves and those intercostal nerves, what we talked about last week is not real. It's going on, but it's not real. You don't sense it. You don't feel it. Movement in the intercostal region and movement between ribs is all done by this thoracic sense of expansion and compression. Those nerves have 2 meanings. Something's distracting and something's coming together. They don't move much in rotation. They don't move much in lateral flexion. But they do move when those intercostals are pulled apart or when those ribs come together. Damage to the internal wall of the thoracic cavity can be felt as a sharp, localized pain because it's injured. So when you damage that area, especially in the internal wall, but through the wall, you're going to feel it. It's going to be sharp because of those nerves. Damage to the visceral pleura is experienced as an unlocalized ache. That was by design, because that pleura is going to be pinched around, moved around. We would be in pain all the time. But the pleura is always protected, because when you have the injured region, i.e. the internal thoracic or the intrathoracic area damaged, the pleura is protected, because the first thing you're going to do is you're going to tense up, tighten up, and restrict that movement. You're going to splint. And so when people splint, and they splint high, their sense goes down. Now the pleura is not protected, because you don't know when you're going to hurt yourself. You're protecting all the time. Can you imagine, Joy, how many people are out there right now are overprotected and under responsive? They don't even know what's going on. They're the same people that can ride these bulls and never get hurt because they're always tense. They're under responsive. And then when they break something, it's no big deal. It'll heal up and they'll do it again, because they're taking all that sensory input and diminishing it. So you don't have to ride a bull to be under responsive. You can get up in the morning and take shallow breaths, take a deep breath in, and live the whole day on that one breath, and just gently not breathe. Get all that air out like you should. Those intercostals were met for complete exhalation. As much you want to get the lowest amount of tidal volume in your system. The least amount means you got to get the most you can out to be very sensory receptive. When you become over sensory minded, you're fearful. Now autonomic automation just kicked in. Now anything, it could be just somebody brisks you a little bit and you're going, whoa, man, don't do that again. So that teeter-totter is set by the somatosensory system in your thoracic intercostals between T1 and T8. Very important. And if we started discussing that years ago with these PRI discussions, it wouldn't have made a lot of sense. But these COVID times allows us to make a little more sense of it. So the first two nerves that supply fibers to the upper limb, in addition, your upper limbs, in addition to the thorax branches, the next four are limited in their distribution to the walls of the thorax, and the lower five supply the walls of the thorax and the abdomen. The seventh intercostal nerve terminates at the xiphoid process at the lower end of the sternum. And that's it. Everything around your thorax is at that point stopped. We have external anterior cutaneous sensation that is there because of the anterior division of the first thoracic nerve, which divides into two branches. The larger leaves the thorax in front of the neck, right in front of the neck of the first rib, and enters the brachial plexus. I just cannot stress how important that brachial plexus is for nervous system sense. And the smaller branch, the first intercostal nerve, the very first intercostal nerve, the smallest one, runs along the first intercostal space right there underneath rib 1 and ends on the front of the chest as the first anterior cutaneous branch of the thorax. It sets the stage for all sense of the thorax, that very first rib and that very first thoracic nerve. Your brachial and anterior lateral chest wall expansion sensation depends on the freedom and the movement of that first rib. If you really want to modulate your rib cage and modulate your sense of yourself, you must keep that first rib moving independent of the second rib and independent of that clavicle. Often sensation of expansion is now the result of that freedom. If you lose that freedom, your sense of expansion goes down. You can get all the ribs to move, Jen, but if that first rib isn't moving, you won't even know it. You might have done a wonderful job with your therapeutic program, but if that first rib doesn't sense it, you don't even know what you're doing. And it won't be long, you'll be holding your breath again. So The sensation and expansion of this area on the right side is limited because of postural restricted movement of the first rib and clavicle. More than likely, if that's going on, you are in the second primary sensory processing disorder category. Your motor behavior based on that sense of that input that was lost by that first rib on the right side sets the stages for rotational impairment. And now your ability to sense yourself goes way down. The second through the sixth thoracic nerves pass forward into the intercostal spaces below the intercostal vessels. And at the back of the chest, they lie between the pleura and the posterior intercostal membranes, which we talked about the week 1 and 2, then run between the internal intercostals, which we talked about last week, and the innermost intercostals, and they end up lying between their pleura in the front and the inner intercostals. So the second through the sixth intercostals are very mindful of where your arm and elbow is at. They're very mindful of activity right here, not back here, not up here, right here. And when you see people holding their arms next to their side when they walk, I want you to remember this slide. They move their body into their arm because that's how they sense themselves. It has nothing to do with their left heel and their right toe at that point. It has everything to do with this talk this evening, with their left heel, right toe not being managed by proper sense of self. They don't get sense because they rely on nonsense. This is sense to them. But that is not forward locomotor sense. That's forward locomotor nonsense. So what I'm trying to get across this evening is we were made to sense movement right on the anterior lateral aspects of our body between the second and sixth thoracic nerve. Please remember that. Please keep that in mind. The fourth intercostal nerve is my favorite nerve because it's the one that makes you feel loved. It's innervated by the cutaneous slow adapting and rapidly adapting mechanoreceptors, especially by the ones that are densely packed under their relar tissue. Innervation subsequently triggers this oxytocin release, which when in the peripheral bloodstream causes myoepithelial cell contraction and expulsion of excreted glandular secretions and lactation. This is an example of a non-nerve innervation muscle reflex, and that's so important because without this hormone, you won't feel this release. Oxytocin is a hormone secreted by the posterior lobe of the pituitary gland. It's known for the cuddle hormone. It's why you are a mammal. You like to be held. You like to be cuddled. It's the love hormone because it releases it, because it is released when people snuggle or bond socially. Jen has this little girl and she puts her to bed at night. I heard her say this morning, Jen, I heard you. And she said, Mommy, will you come what?
Oh, can I cuddle in your bed? Can I come cuddle in your bed?
Can I cuddle in your bed? Well, that child wants her fourth thoracic intercostal nerve to stimulate oxytocin. That's what you want. And when we're not loved and when we don't love our bodies enough, we will search for it. We will find it any way we can. We will hold our arms our side, we'll take our fingers and tense them up, and we'll brace ourselves till all hours of the day. And I just want you to understand that the fourth intercostal nerve is a major nerve in dogs and cats and animals. Why do you think we're different? You want to stroke a dog, stroke the fourth intercostal nerve. They'll love you for death. They'll love you. Tails will wag, they'll be happy. And all I'm trying to get across is that hormone is a thoracic event. It's an intercostal event. The lateral cutaneous branches are all derived from the intercostal nerves. About midway between the vertebrae and the sternum. Well, midway between the vertebrae and the sternum is right under your armpits. That's where activity is going to happen. That's the room where it's going to happen. They pierce the external intercostals, which we talked about last week, and the serratus anterior, which we talked about last week, and then divide into this anterior and posterior branch. Your lateral cutaneous branches do the following thing. They run forward, to the side, underline it, and the forepart of the chest, and the skin, and the 5th and 6th nerves supply the upper digitation of the external oblique abdominals. The posterior branches run backwards and supply the skin over the scapula, a major I&I concept, a major interdisciplinary concept, where the scapula and the latissimus dorsum are making this beautiful contact with a thorax that's begging to be felt. A thorax that wants pressure placed on it. Universal pressure, created by an inhalation mode in the phase of respiration that expands your chest. And when you expand your chest, this system, this posterior branch of this lateral cutaneous nerve is saying, you got yourself, buddy. Now kick in your abdominals. It's not the other way. Abs do not come first on a human body. Intercostals come first. And intercostals are innervated by nerves that we're talking about this evening. So here's a beautiful slide of these wonderful anterior branches and posterior branches of the lateral cutaneous nerves. You can see them, lateral cutaneous branch. And again, they go right around between the sternum and the back of the thorax. And they're on the lateral side of your chest wall. So feeling of body ownership requires self-identification of body parts, and that's achieved by dynamic multi-sensory integration processes that occur from anatomical circuits that receive this somatosthesia, a cutaneous sense, at the occiput and at the anterior parietal lobes of your brain. Projections from these areas into the intraparietal sulcus, inferior parietal cortex, and premotor cortex all strengthen our body and limbs ownership and performance. Placing your hands or placing one's own hands on the surface area of a chest wall will enhance and enhances the foundation for higher cognitive function. And that is necessary. Underline it. It's a necessary activity. Our hands, we have an elbow that allows you to take that hand and touch that chest wall because of that elbow. We were given that ability that's necessary for higher cognitive function related to self-consciousness that emerges during respiration itself, but also strengthens the reflective self-awareness. When I take a breath of air in, Joy, I know I do it. My hands just told me that. My arm just told me I just did it. Out here, I have no clue. Here, I have absolutely no clue. Here, I have no clue. But here, I have a clue. So that's why when we move, one hand is always in a neutral state for that to occur. That's called transition. So you know where you're at. We don't move to the other side without that hand on one side saying, move. Because if I don't have my hands moving correctly, I can't move to the other side. I'm lost. I'm going to fall. But if I have my hand here and the other hand's moving, I'm going to move. And you know people that can't move because you just watch their arms. It's a manifestation of where their body is going because of 3 planes of dimension we talk about, if you like to talk about gait. What I'm talking tonight about is locomotor movement that requires arm swing, hand position, and inside of your arm sense. Associate chest wall and parietal movement during breathing through body and hand autobiographical self-actualization. Self-actualization is what this evening is all about. Now here's some self-actualization techniques for these 3 primary sensory processing disorders. This is the first one.
The first ones are for under-responsiveness.
So, Jan, would you read that when I take a drink?
Standing left centering with right thoracic rotation, left rib sensory awareness, and exhalation focus.
Let's make sure I got this right, Jen. She's standing. She's centered over her left side. She's got this right thoracic rotation going, but she's got this left rib sensory awareness because of under responsiveness on that left side, on that right side, excuse me. Her left rib sensory awareness and exhalation focus. Her left rib exhalation sense is going to be sensed by the placement of her right hand on her right thorax. So when I stand there and I put my left foot behind me and my right foot's in front of me, and I have my right hand on my rib cage and my left hand is going forward, I'm going to make sense. I'm going to sense myself breathing with intercostal sensory processing, not here, and not with my feet down that position, but here. Think of the amount of people out there doing left AFIR and arm reaching with one arm. Well, our institute's built on it, whether it's the left arm or the right arm. Sanguini, that means you got another arm. Well, let's put it to use. These techniques have been around for a while, and I was working with an optometrist when we took them because of this problem, multiple sense issues, which I put under here this afternoon. When you see this problem, sensory discrimination, you know the number one thing you have problems with when you have sensory discrimination issues is the visual system. And it's not even the eyes. It's the visual system's brain cortex. So by putting her right hand on her right chest wall to sense that expansion on the right side, her sense of activity, her left rib sense of activity on the left side is going to go up the minute that that floor comes underneath that left leg. That left leg is going to go down because she's pushing herself. She's not pushing. She's holding her right side from moving to the right. Her right arm is saying, oh, got my right intercostal wall. Wow, that floor is kind of cute. I love it. I'm going to go to it. And I'm feeling the love, really. I'm feeling that oxytocin. I'm feeling it. It's coming in. This is kind of cool. I kind of like it. Take the arm away, and it's meaningless if they don't have thoracic sense. So I love that technique a lot. Let's go to the next one. Jen, if you want to add anything, feel free to do so. Is there an inhalation, exhalation mode in this one? I don't have them in front of me right now.
No.
So that's all it is. What is she doing then, Jen?
She's exhaling and reaching with her left hand as she feels her left ribs move down and in and her trunk slightly side bend to the left.
Lots.
Left heel awareness and grounding throughout the technique.
We didn't put a lot of emphasis on 4 breaths in or 3 breaths in or whatever. We put a lot of emphasis on these techniques, Jan, on what do you feel and what do you sense. Standing left centering with right thoracic rotation, bilateral rib sensory awareness, and inhalation and exhalation integration. Now we got some breathing on this one, right, Jen? It's the same activity, but we got an inhalation exhalation phase. Do you mind if you could read for me the inhalation exhalation phase of it?
Sure. Breathe in through your nose, exhale through your mouth. As you reach forward with your left arm, feeling your left ribs move down and in, and your trunk slightly side bend to the left. Keep left heel awareness and grounding throughout the exercise. Inhale through your nose as you feel right ribs move up and back as the right chest wall expands and the upper trunk rotates slightly to the right.
Now, what Jen just told you is she asked Alex to sense the ribs move up and back when they expand. Alex is now pulling those ribs back, but because of the way her arm is positioned on her rib cage, they will move back and out more easily because there's a place for those ribs to what, Jan? Move to. That apharentation is saying, I now directionally can move them with obliques on my contralateral side and intercostals on the ipsilateral side. And so now not only does she know what she's doing, that's kind of a neat novel idea, to know what to do, she actually knows how she's doing what she does. And as she feels how she's doing what she does, she's encouraged to do more of it because you're in the fourth intercostal region. That's the most pleasurable region of your body to breathe with. There's nothing else in your body that's better than the fourth intercostal region. That's the fourth intercostal region. If you remember, PRI people, it's kind of the area, that fourth vertebrae back there is right in line with your first rib in the front. So when you put your hand on the fourth rib, you're in the same plane of movement as your first rib in the front. And when that activity starts to move, your first rib is saying, man, continue, open me up. Because if you feel it on the lateral side, you know your feeling is coming from what's above it. That's called, Jen, apical expansion. Apical expansion by sensing a rib that's moving back into my right hand. And the right hand is not resisting, it's not pulling, it's not pushing, it's just saying, feel it. What's beautiful about this is the shoulder blade is going to be naturally positioned to do it. And if your shoulder blade's in a natural position to do it, they get done and they start walking, they go, that was the best left abdominal program, Donna, I have ever been on. Wow. Now, I'm not making this stuff up because I've been doing it for years. And we can do that easily with a little multipole sensory integration with whatever else you decide to use, including a mouth splint or gloves, or I use tape and I use shoes, and you can do the same thing. The more sensory input that you supply that individual at that point, the more that individual is going to be able to handle it. The third one is called a seated right thoracic rotation with bilateral rib sensory awareness and inhalation. Again, for inhalation and exhalation integration. It's the same activity, she's just in a seated position. Nice thing about this activity is you're getting the rotation to be more superiorly minded. And if anything, the floor is no longer the issue. The seat you're sitting on is becoming a very, very important pelvis inlet and pelvis outlet pressure gradient activity. This is a great activity for somebody who is seated in a chair all day long and needs a break. It's a wonderful thing to do for your office people, including some of you. So seated. I don't think, Jen, we need to read anything on that one because I think it's the same thing. Now, I think that's the only three I gave you for those, for some under responsiveness and this modulation issue. My goodness, we've got tons of them. But when we took these pictures of Alex, I took them for the reason why we're talking about this evening. We're talking about intercostal nerves, intercostal sensory nerves. Next category, sensory-based motor, people who need to rotate. These techniques are considered, this one's considered for those individuals who experience poor sense of right chest wall rotation. Tons of them in PRI, Jan, tons of them. But during left body stabilization. So here Alex is standing on her left side. She's centered over her left side with right thoracic rotation, right rib sensory awareness with an inhalation focus. That's, again, very similar to what we were doing before, but we're trying to keep her down on that left side. Do you mind reading the part where she's staying on her left leg?
Sure. Place your right hand on your lower rib cage while your left hand stays at your side. Relax and exhale fully through your mouth. Continue to keep the left heel grounded as you inhale through your nose, feeling the right ribs move up and back as your trunk slightly rotates to the right. Continue to keep left heel grounded.
The only regret I had when I took this one, I think about 3 or 4 years ago, was I wish I took Alex's left hand, opened it up, and put it directly on her left thigh. And that would have even been a more powerful sensory awareness program. Again, Alex is feeling left ground with right intercostal rotation and expansion. I don't think we need to say too much more about that particular technique. This one that you all, I think anybody has heard me talk in the past, is magic. Alex is doing some wonderful activity, but her hands really are not touching her, but she is moving her arms past her chest wall. And if you want to know the truth, this technique, up until today, I've never said this to anybody because no one would understand it. This technique, she's not swinging her arms. This technique mandates, Cheryl, that those arms got to go straight back. Guess what, Cheryl? The minute those arms go back, she brushes with life. And when she brushes with life, she says, I can move. I know where I'm at. So the arm movement itself is in such a sagittal plane, she is touching herself. She is going to that lateral intercostal wall. Even if she doesn't touch herself, she's going to want to touch herself. She's going to want to stay close, because the more you come out, the more she's not going to advance the leg below it. The more she gets away, the more she's going to have to use her body to extend to hold herself up. But the more she works on her rotation with where she's at with intercostals of intercostals, intercostal nerves of intercostals, that leg will start moving that body on its own, because that's a natural locomotive movement pattern for intercostal nerves above the dome of the diaphragm. And now her body is saying, lift me, baby, I'm going. You don't have to pull no neck. The air is pushing her rear down and lifting her up in a bilateral, alternating, reciprocating way, which is called a crossover, because she's crossing her hand over. She's taking one arm over the other, over that leg. And as she crosses and lets go, she senses that feeling, because that rotation is what she doesn't get when she gets up on her feet to move. When she gets up on her feet to move, she's got a pattern where she's either oriented one direction, has to converge, and when she converges, those arms do not swing. Here she can diverge, swing, and experience gravitational influence. It is absolutely one of my favorite activities in the world to do for people who do not understand how to breathe. The next activity is an example of a PRI technique for those individuals who experience respiratory distress secondary to poor sensory discrimination of multiple sensory afferentation, sense of stimuli. Here we have Alex. She's standing in front of a mirror. We put a mirror in front of her. And with that left stance, with that left arm reach, Alex is learning how to rotate her right arm. Her hand is touching something. She's touching something. And as she goes by herself, the same thing's going to occur. She's visually seeing herself do it. And then she's got to say to herself something, Jen. I'm not going to make you read all that. It's a long one. But Alex is actually telling the person in the mirror what to do. Alex has a person in the mirror that doesn't look like Alex, because Alex's left hand is now facing Anne's right hand. And Alex's right leg is forward with Anne's left foot. That's Alex looking at Anne in two different situations. That's multiple sense to make sense of Alex when she walks and leaves Anne. When she leaves Anne, she's a new Alex, because the old discrimination, the old lack of discrimination is now new. She can discriminate herself because she's not relying on old sensory processes. It's one of my favorite techniques we would use with people who are very confused when we did something either with their feet or their visual system, not necessarily their teeth. Hour did go by fast. And I don't think we have anything more on that than that picture there. Jen, what are we going to do next week?
Next week, we hope you will join us for our final webinar in this series, where we're going to kind of wrap it all up and pull it together. And I know Ron has some exciting videos to share and kind of pull this all together. But the discussion will be arm swing influence on arterialization and airways.
Appreciate it. Wish we could talk more. You guys have a wonderful evening. I always appreciate you listening to me and talk. I enjoy it. You know I love it, Joy. I love to see all of you. These webinars are on the internet, and you can get them anytime you want. That's the nice thing about having these series. So, I'm proud of them. Jen has done a good job. I think they're concise, and there's a lot of information that relates to the previous webinars. If you know people that are interested in watching this, I would encourage you to encourage them to start with number 1, because if you don't start with number 1, next week is going to be very, very not fun. So I look forward to seeing you next week. You guys have a good week. Happy 4th of July, everybody.